the child with a gastrointestinal condition. In this chapter, we will examine common gastrointestinal disorders that affect infants, children, and adolescents, and discuss the licensed practical nurse's role in providing safe, family-centered care. As we move through this chapter, remember that children are not simply small adults. Their gastrointestinal anatomy and physiology change as they grow, which affects how diseases develop, how symptoms present, and how treatment is provided. Normal growth and development also influence nutritional needs, hydration status, and medication dosing. One of the most important concepts in pediatric gastrointestinal nursing is that children can become dehydrated much more quickly than adults. Because of their higher metabolic rate, greater body water content, and smaller fluid reserves, illnesses that cause vomiting or diarrhea can rapidly lead to electrolyte imbalances and circulatory compromise. Early recognition and intervention are essential. Before we begin, let's review what you should be able to do by the end of this chapter. These learning objectives will guide our discussion and help you focus on the concepts most important for clinical practice and NCLEX preparation. We'll begin by learning the key terminology related to pediatric gastrointestinal disorders. Understanding these terms will make it easier to recognize diseases, communicate with the healthcare team, and interpret documentation. Next, we'll discuss several common gastrointestinal anomalies in infants, including conditions such as pyloric stenosis, Hirschsprung disease, and intussusception. You'll learn how these disorders develop, the signs and symptoms to recognize, how they are diagnosed, and the nursing care required before and after treatment. We'll also examine gastroesophageal reflux and celiac disease, focusing on dietary management, symptom recognition, and family education. Nutrition plays a major role in pediatric gastrointestinal health, so we'll discuss how nutritional deficiencies can affect growth and development, and how nurses can help support healthy nutrition. A major emphasis of this chapter is dehydration. You'll learn why infants and young children are at much greater risk than adults, how to recognize the signs of dehydration early, and how to differentiate between isotonic, hypotonic, and hypertonic dehydration. This is one of the highest yield pediatric topics for both clinical practice and NCLEX. Children with gastrointestinal disorders often present with systemic symptoms that affect the whole body and local symptoms involving the digestive tract. Recognizing both helps identify the underlying condition and prioritize nursing care. Let's start with the systemic symptoms. Failure to thrive, FTT, means a child is not growing or gaining weight as expected. It is a sign that nutrition, absorption, or metabolism is impaired and is commonly seen with chronic gastrointestinal disorders such as celiac disease or severe gastroesophageal reflux. Accurate weights, measurements, and growth chart assessment are essential nursing responsibilities. Another systemic symptom is pruritus, or itching without an obvious allergic cause. Persistent itching may indicate liver dysfunction or biliary disease due to the buildup of bile salts in the skin. Now, let's look at the local symptoms. Abdominal pain is common, but younger children may express it through crying, guarding, or irritability rather than verbalizing discomfort. Vomiting should always be assessed for its characteristics. Projectile vomiting suggests pyloric stenosis, while green or bilious vomiting is an emergency because it may indicate an intestinal obstruction. Diarrhea can rapidly lead to dehydration in infants and young children. Assess stool characteristics and closely monitor hydration status, including urine output, mucous membranes capillary refill, and daily weights. Constipation may result from diet, stool withholding, medications, or congenital disorders such as Hirschsprung disease. Persistent constipation warrants further evaluation. Rectal bleeding and hematemesis or vomiting blood are never normal and require prompt assessment. The color and appearance of the blood can help determine the source of bleeding and guide further treatment. The first congenital gastrointestinal disorder we'll discuss is esophageal atresia with or without a tracheoesophageal fistula, or TEF. This condition develops during fetal growth when the esophagus and trachea fail to separate properly. There are 4 anatomical variations, but you do not need to memorize all 4 for the NCLEX. The most common type is esophageal atresia with a distal tracheoesophageal fistula, where the upper esophagus ends in a blind pouch and the lower portion connects abnormally to the trachea. Because the esophagus is interrupted, food and saliva cannot reach the stomach normally. If a fistula is present, milk or gastric contents can enter the airway, greatly increasing the risk for aspiration and respiratory distress. The classic signs in a newborn include excessive drooling or frothy secretions, choking, coughing, cyanosis during feeding, and difficulty passing a nasogastric tube. If these findings are present, feeding should be stopped immediately and the healthcare provider notified. Before surgery, nursing priorities are to maintain a patent airway, prevent aspiration, keep the infant NPO, provide continuous suction of the upper pouch as ordered, administer intravenous fluids, and position the infant with the head elevated to reduce aspiration risk. Definitive treatment is surgical repair, after which the nurse monitors respiratory status, protects the surgical site, gradually resumes feedings as prescribed, and observes for complications such as anastomotic leak, stricture formation, or recurrent aspiration. For NCLEX, remember the key concepts: excessive drooling, choking with feeds, inability to pass a feeding tube, aspiration risk, NPO status, and surgical correction. These are the findings most commonly tested. Imperforate anus, also called an anorectal malformation, is a congenital defect in which the anal opening does not develop normally during fetal development. Normally, the lower gastrointestinal tract and the anal opening join together to form a continuous passageway. When this process fails, the rectum may end in a blind pouch, or the anus may be absent, narrowed, or connected abnormally to the urinary or reproductive tract. There are 4 types of imperforate anus, ranging from mild narrowing, or stenosis, to complete absence of the anal opening. You do not need to memorize all 4 types for the NCLEX, but you should understand that the severity determines the treatment. Newborns are usually diagnosed during the initial physical examination. Common findings include absence of an anal opening, failure to pass meconium within the first 24 to 48 hours, abdominal distension, vomiting, and feeding intolerance. Some infants may also pass meconium through the urethra or vagina if a fistula is present. Nursing priorities include keeping the infant NPO, monitoring for bowel obstruction, maintaining hydration with intravenous fluids as ordered, and preparing the infant for surgical correction. Parents should be supported with education and reassurance because treatment often occurs shortly after birth. Following surgery, nursing care focuses on pain management, protecting the surgical site, monitoring for infection, and teaching caregivers about wound care or colostomy care if one is required temporarily. For NCLEX, remember the key findings: failure to pass meconium, abdominal distension, absent or abnormal anal opening, and surgical repair as the definitive treatment. Pyloric stenosis is one of the most common gastrointestinal disorders requiring surgery in infancy. It occurs when the pyloric muscle, located between the stomach and the small intestine, becomes abnormally thickened. This narrows the opening, preventing food from emptying from the stomach into the duodenum. Although it is considered a congenital condition, symptoms are usually not present at birth. They typically develop when the infant is 2 to 8 weeks old, as the muscle progressively enlarges. Pyloric stenosis occurs more often in boys, particularly firstborn males, although it can affect any infant. The hallmark sign is projectile non-bilious vomiting shortly after feeding. Because the obstruction is above the duodenum, bile is not present in the vomit. Despite vomiting, infants are usually hungry immediately afterward, often called the hungry vomiter. As the condition progresses, infants develop poor weight gain, dehydration, and electrolyte imbalances, especially hypochloremic, hypokalemic, metabolic alkalosis due to the loss of stomach acid. On physical examination, the healthcare provider may palpate a small, firm, olive-shaped mass in the right upper abdomen, which is a classic finding. Treatment is surgical pyloromyotomy, but surgery is not an emergency. The priority before surgery is correcting dehydration and electrolyte imbalances with intravenous fluids. After surgery, feedings are restarted gradually, and most infants recover quickly with an excellent prognosis. For NCLEX, remember these key points. 2. To 8-week-old infant, projectile non-bilious vomiting, hungry after vomiting, olive-shaped mass, dehydration, and pyloromyotomy after fluid and electrolyte correction. Celiac disease, also called gluten enteropathy or SPRU, is an autoimmune disorder in which ingestion of gluten causes damage to the villi of the small intestine. Because the villi are responsible for absorbing nutrients, this damage leads to malabsorption, making celiac disease one of the most common malabsorption disorders in children. The condition develops in children who have a genetic predisposition, but symptoms usually appear only after gluten-containing foods are introduced, typically between 6 months and 2 years of age. Foods containing wheat, barley, and rye trigger the immune response. Although this slide includes oats, current evidence indicates that pure uncontaminated oats are generally safe for most people with celiac disease. However, because cross-contamination is common, oats should only be introduced if they are labeled gluten-free and approved by the child's healthcare provider or dietitian. Common symptoms include chronic diarrhea, bulky foul-smelling stools, abdominal distension, poor weight gain or failure to thrive, irritability, fatigue, and nutritional deficiencies. Older children may present with constipation, delayed growth, or anemia instead of diarrhea. Diagnosis is based on celiac antibody blood tests and is confirmed with an intestinal biopsy. It is important that the child continues eating gluten until testing is complete, because removing gluten beforehand can produce false negative results. The treatment is a lifelong gluten-free diet. Families should receive education on reading food labels, avoiding hidden sources of gluten, preventing cross-contamination, and ensuring the child receives adequate nutrition. For NCLEX, remember the key concepts. Gluten damages the intestinal villi, causing malabsorption, and the only treatment is lifelong adherence to a gluten-free diet. Hirschsprung disease, also called a ganglionic megacolon, is a congenital disorder in which ganglion cells are absent from a portion of the large intestine, most commonly the sigmoid colon. Without these nerve cells, the affected bowel cannot relax or produce normal peristalsis, creating a functional intestinal obstruction. As stool accumulates behind the obstruction, the healthy portion of the bowel becomes dilated, leading to abdominal distension. Stool that does pass may be thin or ribbon-like because it is forced through the narrowed segment. Hirschsprung disease occurs more frequently in boys and in children with Down syndrome. The presentation depends on the child's age. In newborns, the classic finding is failure to pass meconium within the first 24 to 48 hours of life. They may also develop abdominal distension, vomiting, and feeding intolerance. In infants, common symptoms include chronic constipation, ribbon-like stools, abdominal distension, vomiting, poor feeding, and failure to thrive. In older children, Hirschsprung disease often presents as chronic constipation that does not improve with diet changes or over-the-counter laxatives, prompting further evaluation. Diagnosis is confirmed with a rectal biopsy, which demonstrates the absence of ganglion cells. Treatment is surgical removal of the affected bowel segment, often performed using a pull-through procedure. Some infants may require a temporary colostomy before definitive repair. For the LPN, nursing priorities include monitoring bowel function, maintaining hydration and nutrition, observing for signs of bowel obstruction or enterocolitis, providing postoperative care, and educating families about colostomy care if needed. For NCLX, remember these key findings: failure to pass meconium, chronic constipation, abdominal distension, ribbon-like stools, rectal biopsy for diagnosis, and surgical correction as the definitive treatment. Intussusception occurs when one segment of the intestine telescopes into the section just beyond it, most commonly at the ileocecal valve. As the bowel folds into itself, it pulls the mesentery along with it, compressing the blood vessels that supply the intestine. Initially, this causes a bowel obstruction, but if left untreated, swelling increases, blood flow is reduced, and the affected bowel can become strangulated. Without prompt treatment, the bowel may become ischemic, perforate, and lead to peritonitis, making this a medical emergency. The classic presentation is sudden, severe, intermittent abdominal pain. Infants often draw their knees to their chest, cry intensely, then appear comfortable between episodes. As the condition progresses, they may develop vomiting, lethargy, abdominal distension, and current jelly stools, which contain blood and mucus. A sausage-shaped abdominal mass may also be palpable. Diagnosis is usually confirmed with ultrasound, and many cases can be treated with an air or contrast enema, which is both diagnostic and therapeutic. If the enema is unsuccessful or the bowel has perforated, surgical intervention is required. Today, ultrasound is the preferred imaging study because it is highly accurate and non-invasive. However, an air enema is now the preferred treatment because it can both confirm the diagnosis and reduce the intussusception. This slide refers to a barium enema, but current practice favors an air enema because it is equally effective and has a lower risk of complications if perforation occurs. If enema reduction is unsuccessful, contraindicated, or if the bowel has perforated, surgery is required to manually reduce or remove the affected bowel. Before treatment, nursing priorities include keeping the child NPO, establishing intravenous access, administering fluids to correct dehydration, monitoring vital signs, and assessing for signs of shock or perforation. After successful reduction, continue to observe the child closely because intussusception can recur. especially within the first 24 to 48 hours. Nursing priorities include keeping the child NPO, initiating intravenous fluids, monitoring for signs of shock or perforation, preparing for the reduction procedure or surgery, and closely monitoring for recurrence after treatment. For NCLEX, remember the classic findings: intermittent severe abdominal pain with knees drawn up, current jelly stools, sausage-shaped abdominal mass, ultrasound for diagnosis, and air enema as the preferred initial treatment. Mecal diverticulum is the most common congenital malformation of the gastrointestinal tract. It occurs when a small pouch remains in the ileum because the vitelline or omphalomxenteric duct fails to completely disappear during fetal development. It is usually located near the ileocecal valve and occurs more frequently in boys. Some children remain asymptomatic, but the diverticulum may contain ectopic gastric tissue, which secretes acid and can cause ulceration and bleeding. As a result, the most common symptom is painless, bright red rectal bleeding. Other children may present with abdominal pain that resembles appendicitis or develop intestinal obstruction if the diverticulum becomes inflamed or acts as a lead point for intussusception. The classic way to remember this condition is the rule of 2S. Occurs in about 2% of the population, usually found within 2 feet of the ileocecal valve. About 2 inches long, often presents before 2 years of age, twice as common in boys. Diagnosis is commonly made with a Meckel scan, which detects ectopic gastric tissue. Symptomatic cases are treated with surgical removal of the diverticulum. For the LPN, nursing priorities include assessing for gastrointestinal bleeding, monitoring for signs of anemia or bowel obstruction, preparing the child for diagnostic testing or surgery, and providing postoperative care and family education. For NCLEX, remember the hallmark finding: painless rectal bleeding in a young child with surgical removal as the definitive treatment. Hernias are common congenital conditions in children and occur when a portion of the intestine or other abdominal contents protrudes through a weakness in the abdominal wall. The 2 most common types are inguinal and umbilical hernias. An inguinal hernia occurs when abdominal contents protrude through the inguinal canal in the groin. It is more common in boys, especially premature infants, and may appear as a bulge in the groin or scrotum that becomes more noticeable when the infant cries or strains. The greatest concern with an inguinal hernia is incarceration, where the bowel becomes trapped, or strangulation, where the blood supply is cut off. Signs include a painful, firm, non-reducible bulge, vomiting, abdominal distension, or irritability. These findings require immediate medical attention. Because of this risk, inguinal hernias are typically repaired surgically soon after diagnosis. An umbilical hernia occurs when part of the intestine protrudes through the umbilical ring. It appears as a soft bulge at the umbilicus that becomes more prominent when the infant cries, coughs, or strains. Unlike inguinal hernias, most umbilical hernias close spontaneously by 3 to 5 years of age and rarely become incarcerated. Surgery is considered only if the hernia persists beyond early childhood, becomes very large, or develops complications. For NCLEX, remember the difference: inguinal hernia, higher risk for incarceration, and strangulation usually requires early surgical repair. Umbilical hernia usually self-resolves by age 3 to 5 and is managed with observation unless complications occur. Gastroenteritis is an inflammation of the stomach and intestines and is one of the most common causes of diarrhea in children. It may be caused by viruses, bacteria, parasites, or non-infectious factors. Related terms include colitis, which is inflammation of the colon, and enterocolitis, which involves inflammation of both the small intestine and colon. Although infections are the most common cause of gastroenteritis, several non-infectious factors can also cause diarrhea, including food intolerance, overfeeding, improperly prepared infant formula, and excessive intake of sorbitol, which is found in some fruit juices and sugar-free products. Treatment of gastroenteritis begins with identifying the underlying cause, whether it is viral, bacterial, parasitic, or related to a non-infectious condition. However, regardless of the cause, the priority is correcting fluid and electrolyte losses. The greatest concern with diarrhea in infants and young children is dehydration and electrolyte imbalance. Because children have limited fluid reserves, they can become dehydrated very quickly. If diarrhea is prolonged, they are also at risk for poor weight gain and failure to thrive. Nursing care focuses on assessing hydration status, monitoring intake and output, daily weights, and encouraging oral rehydration therapy when appropriate. Intravenous fluids may be necessary for children with moderate or severe dehydration. Parents should be taught to continue age-appropriate feeding, avoid sugary drinks that can worsen diarrhea, and recognize signs of dehydration, such as decreased urine output, dry mucous membranes, lethargy, and absence of tears. For NCLEX, remember the priority is preventing and treating dehydration, not simply stopping the diarrhea. Hydration, assessment, and fluid replacement are the most important nursing interventions. Vomiting is a forceful expulsion of stomach contents caused by sudden contractions of the diaphragm and abdominal muscles. While occasional vomiting may be harmless, persistent or recurrent vomiting in infants and children always requires further evaluation because it can quickly lead to dehydration and electrolyte imbalances. Repeated vomiting causes the loss of hydrochloric acid and chloride, which can result in metabolic alkalosis. If severe dehydration and electrolyte disturbances are not corrected, they can become life-threatening. Vomiting has many possible causes. In infants, it may result from improper feeding techniques such as overfeeding or swallowing excessive air. It can also be a sign of more serious conditions, including gastrointestinal obstruction, infection, or increased intracranial pressure. This is why careful assessment of the child's age, history, and the characteristics of the vomit is essential. When assessing vomiting, note whether it is projectile, bilious, green, or contains blood. For example, projectile non-bilious vomiting is characteristic of pyloric stenosis, while bilious vomiting suggests an intestinal obstruction and is a surgical emergency. Children who vomit repeatedly are also at risk for aspiration pneumonia, particularly infants and children with decreased levels of consciousness. Nursing care includes positioning the child to protect the airway, monitoring hydration status, replacing fluids as needed, and identifying the underlying cause. For NCLEX, remember that persistent vomiting is never the diagnosis, it is a symptom. Your priorities are to protect the airway, assess hydration and electrolyte status, characterize the vomit, and determine the underlying cause. Gastroesophageal reflux, GER, occurs when the lower esophageal sphincter, LS, is immature or does not close properly, allowing stomach contents to flow back into the esophagus. This is very common in infants, especially preterm infants, because the LES has not fully matured. GER is also more common in children with neuromuscular disorders, such as Down syndrome or cerebral palsy, due to decreased muscle tone and delayed gastric emptying. It's important to distinguish GER from GERD. GER is considered physiologic and is common in healthy infants who spit up but continue to grow and develop normally. Most infants outgrow GER by 12 to 18 months of age as the digestive system matures. GERD, or gastroesophageal reflux disease, occurs when reflux causes complications such as poor weight gain, feeding difficulties, esophagitis, or respiratory problems. Common symptoms include frequent spit-ups or regurgitation after feedings, irritability, arching of the back during feeding, coughing, wheezing, and poor weight gain if the reflux is severe. Treatment usually begins with conservative measures, including smaller, more frequent feedings, keeping the infant upright for 20 to 30 minutes after feeding, and avoiding overfeeding. Some infants may require thickened feedings or medications if symptoms are severe or complications develop. For NCLEX, remember the key points. GR is common in infants, especially preterm infants. Most cases resolve with growth, and conservative feeding and positioning strategies are the first-line treatment. Distinguish normal GER from GERD, which causes poor growth or other complications and requires further evaluation. Diarrhea is defined as a sudden increase in the frequency and looseness of stools compared with the child's normal pattern. In infants, stools may become watery and may appear green or contain mucus or blood. Because normal infant stool patterns vary, it is important to compare the child's current stools with what is typical for that infant. Diarrhea can be classified as acute, chronic, or infectious. Acute diarrhea usually develops suddenly and is most often caused by gastrointestinal infections, but it may also result from medications, food intolerance, food poisoning, or inflammation. Chronic diarrhea lasting longer than 2 weeks suggests an underlying disorder, such as malabsorption, chronic inflammatory disease, or food allergies or intolerances, including celiac disease. Infectious diarrhea is commonly caused by viruses, bacteria, or parasites, with viral gastroenteritis, especially rotavirus and norovirus, being among the most frequent causes in children. The greatest concern with diarrhea is dehydration and electrolyte imbalance. Infants and young children can lose fluids rapidly, making careful assessment essential. Monitor intake and output. daily weights, urine output, mucous membranes, capillary refill, and overall hydration status. Treatment focuses on replacing fluids and electrolytes, usually with oral rehydration solution, ORS, for mild to moderate dehydration, while continuing age-appropriate nutrition whenever possible. For NCLEX, remember that the priority is assessing and treating dehydration, not simply stopping the diarrhea. Persistent diarrhea, blood in the stool, or signs of severe dehydration require prompt medical evaluation. Constipation is defined as difficult or infrequent passage of hard, dry stools. It is one of the most common gastrointestinal complaints in children and is usually functional, meaning there is no underlying disease. However, it can also be a symptom of conditions such as Hirschsprung disease, hypothyroidism, or spinal cord abnormalities. Children with chronic constipation may develop encopresis or fecal soiling. This occurs when liquid stool leaks around a large mass of impacted stool and is often mistaken for diarrhea. It is important to recognize that this is a sign of severe constipation, not true diarrhea. Many factors contribute to constipation, including low-fiber diets, inadequate fluid intake, stool withholding, toilet training issues, changes in routine, psychological stress, and family habits. Because constipation can become a chronic cycle, identifying the underlying cause is essential. Treatment focuses on increasing dietary fiber and fluid intake, encouraging regular toilet habits, promoting physical activity, and using stool softeners or laxatives only as prescribed. Routine use of laxatives or enemas should be discouraged, as they can lead to dependence and do not address the underlying cause. For NCLEX, remember that encopresis usually indicates fecal impaction, and the goals of treatment are to relieve constipation, prevent recurrence, and establish healthy bowel habits through diet, hydration, and behavior modification. Infants and young children are much more vulnerable to fluid and electrolyte imbalances than adults. Understanding why is important because dehydration is one of the most common reasons children are hospitalized. First, infants have a metabolic rate that is 2 to 3 times higher than that of adults on a per kilogram basis. This means they produce more waste products and require more water to eliminate those wastes through the kidneys. Their higher metabolic rate also leads to faster respirations, increasing insensible water loss through the lungs. In addition, infants have a larger body surface area relative to their weight, so they lose more fluid through the skin. Another important difference is body water distribution. Children younger than 2 years have a much larger percentage of their body water in the extracellular fluid compartment. Because extracellular fluid is lost first during illnesses such as vomiting or diarrhea, infants can become dehydrated very quickly. For these reasons, even a short period of vomiting, diarrhea, or poor oral intake can rapidly lead to dehydration, electrolyte imbalance, and circulatory compromise. For NCLEX, remember that infants dehydrate faster than adults because they have a higher metabolic rate, greater insensible water losses, and a larger proportion of body water in the extracellular space. These factors make early assessment and prompt fluid replacement critical. Dehydration occurs when the body loses more fluid than it takes in, leading to fluid and electrolyte imbalances. Because infants and young children have limited fluid reserves, dehydration can develop rapidly and become life-threatening if not treated promptly. When assessing a child with dehydration, we evaluate both the severity and the type of dehydration. This includes a thorough clinical assessment along with laboratory studies such as serum electrolytes to determine the child's sodium level and guide treatment. Dehydration is classified into 3 types based on the serum sodium concentration. Isotonic dehydration is the most common type in children. Water and sodium are lost in approximately equal amounts, so the serum sodium remains normal. Hypotonic dehydration occurs when more sodium is lost than water, resulting in a low serum sodium level. Fluid shifts into the body's cells, which can worsen circulatory volume depletion. Hypertonic dehydration occurs when more water is lost than sodium, causing an elevated serum sodium level. Fluid shifts out of the cells, and children may appear less dehydrated than they actually are, while being at increased risk for neurologic complications. Regardless of the type, nursing priorities include assessing hydration status, monitoring vital signs, intake and output, daily weights, urine output, mental status, and laboratory values, then replacing fluids carefully according to the child's condition. For NCLEX, remember that isotonic dehydration is the most common form in children, and dehydration is classified according to the serum sodium level, which reflects the relative loss of water and electrolytes. Overhydration, also called fluid volume excess, occurs when the body receives or retains more fluid than it can eliminate. Although less common than dehydration in children, it can occur with excessive intravenous fluid administration, kidney disease, heart failure, or conditions that cause sodium and water retention. The excess fluid moves into the interstitial spaces, producing edema or swelling. Interstitial fluid surrounds the body's cells and normally contains very little protein. When sodium and water are retained, or when fluid cannot return effectively to the bloodstream, edema develops. Several factors can contribute to edema, including sodium retention, poor circulation, impaired lymphatic drainage, and low blood protein levels. Low protein, especially albumin, reduces the blood's oncotic pressure, allowing fluid to leak from the blood vessels into the tissues. In severe cases, fluid accumulation becomes widespread throughout the body, a condition known as anasarca or generalized edema. Nursing assessment focuses on identifying signs of fluid overload, including rapid weight gain, edema, elevated blood pressure, crackles in the lungs, increasing respiratory effort, and decreased oxygen saturation. Monitor intake and output, daily weights, and respiratory status closely, especially in children receiving intravenous fluids. For NCLEX, remember that daily weight is the most sensitive indicator of changes in fluid balance. Also remember that anasarca refers to severe generalized edema, and low albumin levels can contribute to edema by reducing oncotic pressure. Failure to thrive, FTT, describes a child who fails to gain weight appropriately or loses weight, resulting in poor growth. It is not a diagnosis itself, but rather a sign that an underlying problem is interfering with normal growth and nutrition. FTT is generally divided into organic and non-organic causes. Organic failure to thrive, OFTT, results from an underlying medical condition such as congenital heart disease, malabsorption disorders like celiac disease, chronic infections, or other illnesses that increase nutritional needs or reduce nutrient absorption. Non-organic failure to thrive, NFTT, is related to environmental, social, or behavioral factors such as inadequate nutrition, feeding difficulties, caregiver stress, or neglect. Many children actually have a combination of both organic and non-organic factors. Because adequate nutrition is essential for growth, children with FTT may experience delayed physical growth and developmental delays if the condition is not recognized and treated early. When evaluating a child with FTT, nurses assess growth measurements, feeding history, developmental milestones, family interactions, and psychosocial factors. A pregnancy and birth history may also provide clues to factors that affect parent-child bonding or feeding. Treatment focuses on identifying and correcting the underlying cause, providing adequate nutrition, monitoring growth closely, and supporting the family. Some families may benefit from nutrition counseling, feeding therapy, or social service resources. For NCLEX, remember that FTT is a clinical finding, not a disease. Your priorities are to identify the underlying cause, support adequate nutrition, monitor growth over time, and address both medical and psychosocial factors that may contribute to poor weight gain. Kwashiorkor is a severe form of protein-energy malnutrition caused by an inadequate intake of protein, even though the child may be receiving enough calories from carbohydrates. Without adequate protein, the body cannot maintain normal growth, tissue repair, or fluid balance. A hallmark feature of kwashiorkor is edema. Because protein levels, especially albumin, become very low, fluid leaks from the blood vessels into the tissues, causing swelling of the face, abdomen, and extremities. This is why children with kwashiorkor may appear well-fed despite being severely malnourished. Other signs include poor growth, muscle wasting, irritability, thinner, sparse hair with color changes, flaky or peeling skin, enlarged fatty liver, frequent infections, and delayed wound healing. Kwashiorkor is most commonly seen in developing countries where access to protein-rich foods is limited. But it can also occur in children with severe malabsorption disorders, chronic illnesses, or prolonged inadequate protein intake. Treatment involves careful nutritional rehabilitation, correcting fluid and electrolyte imbalances, treating infections, and gradually increasing protein and calorie intake. Rapid refeeding should be avoided because it can lead to refeeding syndrome, a potentially life-threatening shift in fluids and electrolytes. For NCLEX, remember the hallmark finding: edema caused by severe protein deficiency. Think, protein deficiency equals edema, whereas marasmus is characterized by severe calorie deficiency with marked wasting but little or no edema. Rickets is a disorder of growing bones caused by a deficiency of vitamin D and sometimes inadequate calcium or phosphorus. Vitamin D is essential because it allows the body to absorb calcium and phosphorus, which are needed for normal bone mineralization. Without enough vitamin D, bones become soft, weak, and easily deformed. Vitamin D is obtained through diet and produced in the skin after exposure to sunlight. Children who have limited sun exposure, inadequate dietary intake, or disorders that interfere with vitamin D absorption are at increased risk. Classic signs of rickets include bowed legs, knock knees, enlargement of the wrists and ankles, delayed tooth eruption or poorly formed teeth, and an enlargement of the rib junctions known as the rachitic rosary. Children may also have delayed growth, muscle weakness, and bone pain. Diagnosis is based on physical examination, laboratory findings such as low vitamin D, and abnormal calcium and phosphorus levels, and X-rays showing poor bone mineralization. Treatment includes vitamin D supplementation, ensuring adequate calcium intake, encouraging safe outdoor sunlight exposure, and promoting normal physical activity. Most children improve significantly when treatment is started early. For NCLEX, remember the key concepts. Vitamin D deficiency leads to poor calcium absorption, resulting in soft bones, bowed legs, and rachitic rosary. Treatment focuses on vitamin D replacement, adequate calcium intake, and appropriate sunlight exposure. Scurvy is caused by a vitamin C deficiency. Although it is uncommon today, it can still occur in children with very restricted diets, food insecurity, or conditions that limit nutrient absorption. Vitamin C is essential for collagen production, which is needed to maintain healthy skin, blood vessels, gums, bones, and connective tissue. Without enough vitamin C, tissues become fragile and heal poorly. Common symptoms include fatigue, irritability, joint and bone pain, swollen or bleeding gums, loose teeth, easy bruising, poor wound healing, and small pinpoint hemorrhages called petechia. An important nursing point is that vitamin C is not stored in the body, so it must be consumed daily. It is also easily destroyed by heat and prolonged exposure to air, so fresh fruits and vegetables are the best sources. Treatment consists of vitamin C supplementation and increasing foods rich in vitamin C, such as citrus fruits, strawberries, tomatoes, bell peppers, broccoli, and leafy green vegetables. Symptoms usually begin to improve within a few days after treatment is started. For NCLEX, remember the hallmark findings: bleeding gums, poor wound healing, easy bruising, and vitamin C deficiency. The treatment is vitamin C replacement and a diet rich in fresh fruits and vegetables. Appendicitis is the most common cause of emergency abdominal surgery in children. It occurs when the appendix, a small pouch attached to the cecum, becomes obstructed. The blockage is most commonly caused by fecal material, a fecalith, or enlarged lymphoid tissue, often following a viral illness. Less commonly, parasites or other foreign material may obstruct the lumen. Once blocked, mucus and bacteria become trapped, causing swelling, edema, increased pressure, and bacterial growth. If untreated, the appendix can become gangrenous and eventually rupture, leading to peritonitis and sepsis, which are life-threatening complications. The classic symptom is abdominal pain that begins around the umbilicus. As inflammation progresses and irritates the peritoneum, the pain migrates to the right lower quadrant, RLQ, usually over several hours. This migration of pain is a classic NCLEX finding. Other common symptoms include loss of appetite, nausea, vomiting, low-grade fever, abdominal tenderness, rebound tenderness, guarding, and pain that worsens with movement, coughing, or walking. Diagnosis is based on the history, physical examination, laboratory studies, including an elevated white blood cell count, and imaging such as ultrasound or computed tomography, CT, when needed. Treatment is surgical removal of the appendix, appendectomy, along with intravenous fluids and antibiotics. Do not apply heat or administer laxatives or enemas to a child with suspected appendicitis because these interventions can increase the risk of rupture. Keep the child NPO in preparation for surgery. For NCLEX, remember these key points: periumbilical pain that migrates to the RLQ, nausea, vomiting, and fever NPO, intravenous fluids, antibiotics, and appendectomy. Avoid heat, enemas, and laxatives due to the risk of perforation. Thrush or oral candidiasis is a fungal infection caused by Candida albicans. It is common in infants, especially after antibiotic therapy, in children with weakened immune systems, or after using inhaled corticosteroids without rinsing the mouth. The classic finding is white, creamy patches on the tongue, inner cheeks, gums, or roof of the mouth. Unlike milk residue, these patches cannot be easily wiped away and may leave a red bleeding surface if scraped. Because the lesions can be painful, infants may have poor feeding, fussiness, or decreased appetite. If untreated, the infection can spread into the esophagus, making swallowing painful and feeding even more difficult. Treatment usually consists of a topical antifungal medication, most commonly N-istatin oral suspension. The medication should be placed directly on the affected areas and kept in contact with the white patches for as long as possible before swallowing. Treatment should continue for the full prescribed course, even if the lesions improve. Teaching families is an important part of care. Parents should sterilize bottle nipples and pacifiers, wash hands frequently, and if the infant is breastfeeding, the mother's nipples should also be assessed and treated if necessary to prevent reinfection. With appropriate treatment, thrush usually resolves within several days to 2 weeks. For NCSLX, remember the key findings: white patches that do not wipe off, pain with feeding, treatment with nystatin, and prevention of reinfection by cleaning feeding equipment and treating both infant and breastfeeding parent when indicated. Pinworms, also called enterobiasis, are the most common intestinal worm infection in children. They are small, thin white worms that resemble a piece of thread. The adult worms live in the large intestine, but at night the female worm migrates to the skin around the anus to lay eggs. This causes the classic symptom of intense perianal itching, especially at night. Children may have difficulty sleeping, become irritable, or scratch the area, allowing eggs to collect under the fingernails. Within a few hours, the eggs become infectious. When contaminated fingers, food, or objects are placed in the mouth, the eggs are swallowed, hatch in the intestine, and the cycle begins again. This is why reinfection is very common. The diagnosis is made using the Scotch tape test, performed first thing in the morning before the child bathes or uses the bathroom. Clear adhesive tape is pressed against the skin around the anus and examined under a microscope for eggs. Treatment consists of anthelmintic medications such as albendazole, mebendazole, or pyrantel pemoate. Because reinfection spreads easily, all household members are usually treated at the same time, and a second dose is commonly given 2 weeks later to kill any newly hatched worms. Parents should also be taught to wash hands frequently, keep fingernails short, discourage nail biting and scratching, wash bedding and clothing in hot water, and clean household surfaces to reduce reinfection. For NCLEX, remember the key points: nocturnal perianal itching, Scotch tape test for diagnosis oral ingestion of eggs spreads the infection, treat the child and household members while reinforcing good hand hygiene to prevent reinfection. Poisoning is a leading cause of injury in young children, especially those between 1 and 5 years of age, because they naturally explore their environment by putting objects into their mouths. Most poisonings are accidental and preventable. The goals of treatment are to remove or limit exposure to the poison, prevent further absorption, provide supportive care, and obtain expert guidance as quickly as possible. The first step is to ensure the child's airway, breathing, and circulation are stable. If the child is unconscious, having seizures, or not breathing normally, call 911 immediately. If the child is stable, contact the Poison Control Center. Now, right away, the nationwide number is 1-800-222-1222, and experts are available 24 hours a day to provide treatment recommendations based on the specific poison involved. Parents should not induce vomiting unless specifically instructed by Poison Control, as this can worsen the injury, especially after ingestion of corrosive substances or hydrocarbons. Likewise, do not give food, drink, or home remedies unless directed by a healthcare professional. Supportive care depends on the poison involved and may include oxygen, intravenous fluids, antidotes, activated charcoal in selected cases, or close monitoring in the emergency department. Teaching families is equally important. Medications and household chemicals should be stored in their original containers, locked up and kept out of children's reach. Child-resistant packaging helps but is not childproof. For NCLX, remember the priorities. Assess airway, breathing, and circulation first. Call Poison Control, 1-800-222-1222 for guidance. Do not induce vomiting unless specifically instructed. Focus on supportive care while preventing further poison absorption. Lead poisoning, also called plumism, occurs when a child repeatedly ingests or absorbs lead over time. Young children are at greatest risk because they frequently place objects in their mouths and absorb lead more efficiently than adults. The most common source is deteriorating lead-based paint found in homes built before 1978. Children may ingest lead by chewing on painted windowsills, toys, or by swallowing contaminated dust or soil. Children with pica, the habit of eating non-food substances, are at especially high risk. Lead is a neurotoxin that primarily affects the central nervous system. Even relatively low blood lead levels can cause learning disabilities, decreased IQ, behavioral problems, and developmental delays. Severe poisoning may result in encephalopathy, seizures, coma, or permanent cognitive impairment. Diagnosis is confirmed with a blood lead level. Treatment begins with eliminating the source of exposure. Children with elevated lead levels may require chelation therapy, depending on the blood lead concentration and symptoms. For NCLEX, remember these key points. Think older homes with peeling paint. Pica is a major risk factor. Lead primarily damages the brain and nervous system. Prevention and early screening are essential because neurologic damage may be irreversible. Foreign body ingestion is most common in children between 6 months and 3 years of age because they naturally explore objects by putting them in their mouths. Fortunately, about 80% of swallowed objects pass through the gastrointestinal tract without intervention, usually within 6 days. Parents should monitor stools for passage of the object and follow the healthcare provider's recommendations. Parents should not give laxatives or alter the child's diet unless instructed by the provider. A normal diet helps maintain normal intestinal movement. Some ingestions are medical emergencies and require immediate evaluation. These include button batteries, which can rapidly cause tissue burns, multiple magnets or a magnet with another metal object, which can trap bowel tissue, sharp or pointed objects, which increase the risk of perforation, any child with drooling, difficulty swallowing, chest pain, vomiting, abdominal pain, or respiratory distress. For NCLEX, remember, most objects pass spontaneously. Never delay evaluation for button batteries or magnets. Teach parents to avoid laxatives and seek medical attention if symptoms develop. Today we'll begin our discussion of pediatric genitourinary GU disorders, focusing on conditions affecting the kidneys, ureters, bladder, urethra, and reproductive organs. Because the urinary system plays a vital role in maintaining fluid and electrolyte balance, even minor abnormalities can have significant effects on a child's health. As LPNs, you'll need to recognize common pediatric GU disorders, identify signs of urinary tract infection, dehydration, urinary obstruction, and renal dysfunction, and provide safe, family-centered nursing care. Throughout this chapter, we'll emphasize assessment findings, diagnostic testing, nursing interventions, patient and family education, and NCLEX priorities. By the end of this section, you should be able to identify common pediatric genitourinary disorders, recognize abnormal urinary assessment findings, explain priority nursing interventions, provide appropriate patient and family education, apply clinical judgment to pediatric GU scenarios, NCLE's tip. Always assess urine output, hydration status, blood pressure, and daily weight when evaluating children with renal or urinary disorders. These are key indicators of kidney function and fluid balance. In this chapter, we'll examine common pediatric genitourinary disorders and how they affect kidney function, urinary elimination, fluid balance, and growth and development. We'll begin with a review of normal pediatric renal anatomy and physiology, including the nephron, normal urine output, and common diagnostic tests. Understanding normal function will make it easier to recognize abnormalities. Next, we'll discuss congenital urinary tract anomalies and urinary tract infections, including risk factors, assessment findings, prevention, and nursing care. We'll then compare two important renal disorders, nephrotic syndrome and acute glomerulonephritis, focusing on their pathophysiology, assessment findings, treatment, and nursing priorities. These conditions are commonly tested on the NCLEX because they have similar presentations but different underlying causes and management. Finally, we'll cover Wilms tumor, cryptorchidism, undescended testes, and important nursing considerations for children undergoing genitourinary surgery, including postoperative care and family education. When evaluating pediatric urinary disorders, healthcare providers use a variety of diagnostic tests to assess kidney function, urinary tract anatomy, and bladder function. As LPNs, you should understand the purpose of the most common studies. Urinalysis, UA, is the first-line test for most urinary complaints. It helps detect infection, blood, protein, glucose, ketones, and other abnormalities. A renal ultrasound is a painless, non-invasive test that evaluates the kidneys and bladder for structural abnormalities, hydronephrosis, cysts, masses, or urinary obstruction. Avoiding cystoarthrogram, VCUG, is commonly performed after recurrent urinary tract infections. Contrast is instilled into the bladder through a catheter, while X-rays are taken during urination to detect vesicoreteral reflux, VUR, the backward flow of urine from the bladder into the ureters. A CT scan provides detailed images of the urinary tract and may be used to evaluate trauma, stones, tumors, or congenital abnormalities. A cystoscopy allows the provider to directly visualize the urethra and bladder using a flexible scope. It may also be used to remove foreign bodies or evaluate structural abnormalities. A renal biopsy is performed less frequently but may be necessary to diagnose certain kidney diseases such as nephrotic syndrome or glomerulonephritis. NCLX, PEARLS. Urinalysis is usually the first diagnostic test for urinary symptoms. Ultrasound is the preferred initial imaging study because it is non-invasive and radiation-free. VCUG is the gold standard for diagnosing vesicoureteral reflux, VUR. After a renal biopsy, monitor for bleeding, check vital signs, inspect the urine for hematuria, and keep the child on bed rest as ordered. This is a common NCLEX question. These are common terms you will encounter when assessing children with urinary disorders. Understanding them will help you recognize abnormal urinary patterns and communicate findings accurately. Dysuria is painful or burning urination. It is commonly associated with urinary tract infections, UTIs. Frequency means urinating more often than normal, often in small amounts. Urgency is the sudden, strong urge to urinate that is difficult to delay. Nocturia is waking during the night to urinate. Although common in adults, it is less common in children and may indicate an underlying problem. Enuresis is involuntary urination after the age when bladder control is expected, most commonly nighttime bedwetting. Polyuria means excessive urine output. Causes include diabetes mellitus, diabetes insipidus, excess fluid intake, or certain medications. Oliguria means decreased urine output. It may indicate dehydration, shock, acute kidney injury, or urinary obstruction and should always be reported promptly. NCLX, PEARLS dysuria plus frequency plus urgency =, think UTI. Polyuria =, too much urine. Oliguria =, too little urine, which is often more concerning because it may indicate decreased kidney perfusion or renal failure. Enuresis is common in younger children, but should be evaluated if it persists beyond the expected age of bladder control or develops suddenly after continence has been established. Phimosis is a condition in which the foreskin is too tight to be pulled back over the glans penis. In infants and young boys, this is often physiologic, meaning it is a normal developmental finding. As boys grow, the foreskin gradually becomes more retractable. Parents and caregivers should never forcibly retract the foreskin. Forceful retraction can cause pain, bleeding, scarring, and may lead to paraphimosis. If phimosis causes recurrent infections, urinary obstruction, pain, or persists beyond childhood, treatment may include topical corticosteroid cream or circumcision. Paraphimosis occurs when a retracted foreskin becomes trapped behind the glans and cannot be pulled forward again. The tight foreskin acts like a constricting band, causing swelling and reducing blood flow to the penis. This is a true urologic emergency because prolonged loss of circulation can lead to tissue ischemia and necrosis. Treatment requires prompt manual reduction or surgical intervention if manual reduction is unsuccessful. NCLX PEARLS. Phimosis =, cannot retract the foreskin. Paraphimosis =, cannot replace the foreskin after it has been retracted. Never forcibly retract an infant's foreskin. Paraphimosis is a medical emergency because it can compromise blood flow to the penis. After any catheterization or examination, always return the foreskin to its normal position. To prevent paraphimosis, this is a common NCLEX question. Epispadias and hypospadias are congenital abnormalities in which the urethral opening is not located at the tip of the penis. With epispadias, the urinary meatus is located on the upper dorsal surface of the penis. This condition is much less common than hypospadias and may be associated with bladder exstrophy. With hypospadias, the urinary meatus is located on the underside, ventral surface, of the penis. The opening may be just below the tip or farther down the shaft near the scrotum, depending on severity. Many boys with hypospadias also have chordee, a downward curvature of the penis that becomes more noticeable with erection. Chordee may interfere with normal urination and future sexual function if left untreated. Treatment is surgical repair, usually performed between 6 and 18 months of age. Mild cases may not require surgery, but more significant defects generally do. One of the most important nursing considerations is not to circumcise these infants. The foreskin is often used by the surgeon to reconstruct the urethra during repair. NCLX, PEARLS, epispadias =, E for exit on top, dorsal surface. Hypospadias =, hypo means below ventral surface. Never circumcise an infant with hypospadias or epispadias until evaluated by pediatric urology. Monitor postoperative repair for adequate urine output, catheter patency, infection, and proper healing. Teach parents to avoid straddle toys and rough play until healing is complete after surgery. Bladder exstrophy is a rare congenital anomaly in which the lower abdominal wall and the anterior wall of the bladder fail to close during fetal development. As a result, the bladder is exposed on the outside of the abdomen. The exposed bladder mucosa continuously leaks urine, placing the infant at high risk for infection, dehydration, and skin breakdown. Prenatal ultrasound may detect this condition before birth. The priority nursing intervention is protecting the exposed bladder. Cover the bladder with a sterile, saline-moistened, non-adherent dressing to keep the tissue moist and prevent trauma and infection. The dressing should be changed frequently using sterile technique. To protect the bladder while allowing urine to drain freely, place the diaper underneath the exposed bladder, not over it. Frequent skincare is essential to prevent excoriation from continuous urine exposure. Position the infant on the back or side to reduce pressure on the exposed bladder and promote urine drainage. Definitive treatment is surgical closure, which is typically performed within the first 48 to 72 hours of life, although timing may vary depending on the infant's condition and associated anomalies. NCLX, Pearl's priority equal sign. Protect the exposed bladder. Keep the bladder moist with a sterile, saline-moistened dressing. Use a non-adherent dressing. Never allow the mucosa to dry out. Place the diaper under, not over, the bladder. Prevent infection and skin breakdown until surgical repair. Bladder exstrophy is commonly associated with epispadias, so these conditions often occur together. Obstructive uropathy is any condition that blocks the normal flow of urine. When urine cannot drain properly, pressure builds within the urinary tract, which can eventually damage the kidneys. Common causes include kidney stones, calculi, tumors, urethral strictures, scar tissue, or congenital abnormalities. In children, congenital defects are a much more common cause than stones. One important complication is hydronephrosis, which is dilation or swelling of the renal pelvis and calluses caused by urine backing up into the kidney. If untreated, prolonged obstruction can decrease kidney function and eventually result in chronic kidney disease. The slide also mentions polycystic kidney disease. While this condition is not a classic cause of obstructive uropathy, enlarged cystic kidneys can occasionally contribute to urinary obstruction. More importantly, it is an inherited disorder characterized by multiple fluid-filled cysts that gradually impair kidney function. Some children require a urinary diversion, such as a urostomy, when urine cannot drain normally. Nursing care includes monitoring urine output and stoma function, preventing skin breakdown around the stoma, preventing infection, teaching families long-term stoma care. Children with urinary diversions often face developmental and psychosocial challenges. Toddlers may experience delays in toilet training. School-age children may struggle with body image and feeling different from peers. Adolescents commonly have concerns about appearance, self-esteem, dating, and sexuality. The nurse plays an important role in supporting normal development, promoting independence, and encouraging participation in age-appropriate activities. NCLEX Pearl's hydronephrosis equal sign urine backs up into the kidney because of obstruction. Untreated obstruction can cause permanent kidney damage. Monitor for decreased urine output, flank pain, urinary tract infections, and elevated blood pressure. Children with urinary diversions require stoma care, skin protection, and psychosocial support. Remember the developmental concerns: toddler equal sign, toilet training, school age equal sign body image and peer acceptance, adolescent equal sign self-esteem and sexuality. Urinary tract infections, UTIs, are among the most common bacterial infections in children. E. coli is the most common cause. Girls are at greater risk because their urethra is shorter, allowing bacteria to reach the bladder more easily. Symptoms include fever, dysuria, urinary frequency, urgency, foul-smelling urine, abdominal pain, and vomiting. Infants may present only with fever, irritability, or poor feeding. Diagnosis is made with a urinalysis and urine culture, ideally collected before antibiotics are started. Treatment includes antibiotics, increased fluids, frequent voiding, and good perineal hygiene. NCLEX Pearl's E. coli is the most common cause. Collect a urine culture before antibiotics whenever possible. Teach girls to wipe front to back. Recurrent UTIs may indicate vesicoureteral reflux, VAR. Nephrotic syndrome is a kidney disorder in which the glomeruli become more permeable, allowing large amounts of protein to leak into the urine. The loss of protein causes hypoalbuminemia, which leads to generalized edema. It most commonly affects boys between 2 and 7 years of age and is often caused by minimal change disease, which usually responds well to corticosteroid therapy. Nursing care focuses on monitoring daily weight, intake and output, urine protein and edema, preventing infection, and teaching parents how to monitor the child at home. Live vaccines should be avoided during immunosuppressive therapy. NCLX, Pearl's proteinuria plus edema plus hypoalbuminemia equals sign nephrotic syndrome. Daily weight is the best indicator of fluid status. Monitor for infection, a major complication. Most children respond well to corticosteroids. Acute glomerulonephritis, AGN, is an inflammatory kidney disorder that commonly develops 1 to 3 weeks after a group A streptococcal throat or skin infection. The body's immune response damages the glomeruli, reducing their ability to filter blood. Children typically present with tea or cola-colored urine, hematuria, edema, especially around the eyes, decreased urine output, and hypertension. Mild proteinuria may also be present. Treatment is primarily supportive and includes treating any remaining streptococcal infection, controlling blood pressure, restricting sodium and fluids if needed, and monitoring kidney function. Most children recover completely within a few weeks. NCLX. Pearl's tea or cola-colored urine equals sign acute glomerulonephritis. Often occurs 1 to 3 weeks after strep throat. Priority assessments, blood pressure, urine output, edema, and daily weight. Differentiate from nephrotic syndrome AGN, hematuria plus hypertension. Nephrotic syndrome, massive proteinuria plus generalized edema. Wilms's tumor, nephroblastoma, is the most common kidney cancer in young children, typically occurring between 2 and 5 years of age. It usually presents as a firm, painless abdominal mass that is often discovered by a parent during bathing or dressing. Children may also have hematuria, hypertension, abdominal pain, fever, or weight loss, although many are otherwise healthy. The most important nursing intervention is never palpate the abdomen once Wilms' tumor is suspected or diagnosed. Palpation can rupture the encapsulated tumor, allowing cancer cells to spread throughout the abdomen. A no abdominal palpation sign should be placed at the bedside, and all caregivers should be informed. Diagnosis is made with imaging studies such as ultrasound or CT scan. Treatment usually includes surgical removal of the affected kidney, nephrectomy, followed by chemotherapy, and radiation therapy if indicated. NCLEX Pearl's painless abdominal mass equals sign, think Wilms's tumor. Never palpate the abdomen because of the risk of tumor rupture. Monitor blood pressure as hypertension is common. Primary treatment is nephrectomy followed by chemotherapy. A hydrocele is a collection of fluid within the sac surrounding the testicle, causing painless swelling of the scrotum. It is common in newborn boys and is usually present at birth. Most hydroceles resolve spontaneously during the first year of life and require only observation. If the hydrocele persists beyond 12 to 18 months, enlarges, or is associated with an inguinal hernia, surgical repair, hydrocelectomy, may be needed. Hydrocele are typically not painful and do not affect fertility. Diagnosis is often confirmed by transillumination, where light passes through the fluid-filled sac. NCLX Pearls, hydrocele equals sign painless fluid-filled scrotal swelling. Transillumination is positive because the sac contains fluid. Most resolve without treatment during infancy. Surgery is indicated if the hydrocele persists, enlarges, or is associated with a hernia. Cryptor or both testes to descend into the scrotum. It is more commonly unilateral and is one of the most common congenital abnormalities of the male reproductive system. An undescended testis remains at body temperature, which impairs normal sperm production. If left untreated, it increases the risk for infertility and testicular cancer, especially if both testes are affected. Testosterone production is usually normal, so secondary sexual characteristics develop normally. Many testes descend spontaneously during the first few months of life. If descent has not occurred by 6 months, spontaneous descent is unlikely. Orchiopexy is recommended, ideally before 12 to 18 months of age, to improve fertility potential and reduce cancer risk. NCLX Pearl's cryptorchidism equals sign undescended testis, often associated with an inguinal hernia. Orchiopexy before 12 to 18 months improves outcomes. Untreated cryptorchidism increases the risk for infertility and testicular cancer. Hormone production is usually normal, so secondary sexual characteristics are not affected. Children between 3 and 6 years of age are becoming more aware of their bodies and the differences between boys and girls. During this developmental stage, surgery involving the urinary or genital system can be especially stressful because children may fear injury, loss of body parts, or punishment. The nurse should prepare the child using simple, honest, age-appropriate explanations, therapeutic play when appropriate, and reassurance that the surgery is meant to help them get better. Avoid medical jargon and answer questions truthfully. Parents play a critical role in reducing anxiety. Encourage parental presence before and after surgery. Maintain normal routines when possible, provide adequate pain control, and support the child's emotional needs throughout recovery. NCLX. Pearl's preschool children often interpret illness or surgery as punishment. Provide developmentally appropriate explanations before procedures. Encourage parental presence to decrease anxiety. Reassure the child that surgery does not change their identity or gender.